Namaskar, I am Dr. K.K. Agarwal, Editor-in-Chief, IGCP Group. Greetings from our MedTalks division. Today we are going to have an interactive session on lasers and cosmetic procedures in dermatology. The expert speaker will be Dr. Anil Ganju, who is a consultant dermatologist and cutaneous laser surgeon in Delhi. The purpose of this video is to provide you an academic feast in the field of both surgical and non-surgical procedures in cosmetology. Today, large number of patients are going to dermatologists for cosmetic procedures, whether they are surgical or non-surgical. There is increased awareness. Now these types of procedures are available as daycare with most of the dermatologists, and our new dermatologists and also people who have not practiced cosmetology needs to know about these procedures. Let's learn and interact with Dr. Anil Ganju, and if you find that there are any queries, you can write to us at editorial@igcp.com and we will get it answered by Dr. Anil Ganju. Thank you.
Hello friends, I am Dr. Anil Ganju, consultant dermatologist and laser surgeon from Delhi. I am the president of the SARC AAD, and today we are going to talk about certain cosmetic procedures and the use of lasers in dermatology. Now, cosmetic procedures have increased overall, probably because of the economic growth in our country and society and a better affordability amongst our general classes. There's a booming middle class and they have a lot of disposable incomes to spend, and there is also increasing awareness amongst the general population about these cosmetic procedures. Now, they include surgical, non-surgical procedures. They are basically aimed at reshaping structures of the body that have lost shape due to aging, due to environmental factors like sunlight exposure, cigarette smoking, pollution, etc., etc. Basically, what we aim at with these cosmetic procedures is facial contouring, rejuvenation of the face, rejuvenation of the skin, the tone, color, etc. We also include things like breast augmentation and enhancement, body contouring, etc. in these procedures. Now, the new things that have been happening in this world is one of the important things is the botulinum toxin. Now, this is an injectable neuromodulator or a neuro inhibitor that is derived from neurotoxins that are produced by bacteria called Clostridium botulinum. It displays a very good efficacy in various aesthetic and medical problems, and basically it inhibits the neurotransmission at the neuromuscular junction and leads to relaxation of the muscles. The botulinum toxin A has shown a good efficacy in reducing the dynamic lines on the face. It was developed in the US for these aesthetic procedures. The first one that was developed was the Ona botulinum toxin A. An alternative to this is the Abu botulinum toxin A and also the Inco botulinum toxin A. The US FDA approved its use for cosmetic use, basically for use in glabellar lines and for the use in canthal lines or the crow's feet as they are called, and the Inco and the Abo botulinum toxins are approved only for use of glabellar lines. Now, after the botulinum toxin, the other thing that has been happening in the world of cosmetics is the chemical peels. Now, the chemical peels basically are chemicals that produce controlled burns on the surface of the skin. We apply these chemicals on the skin and wait for them to act, and then either remove them or we seal them depending upon the kind of chemical that we have applied. We produce a controlled destruction of the superficial layers of the skin to the level of usually the epidermis, but sometimes the dermis also. This is followed by exfoliation and rejuvenation and regeneration of new epidermis, and the skin gets younger and younger. Various kinds of chemical peels have been made available individually and in combinations. We use them sequentially, number of kinds of peels ranging from alpha hydroxy acids, beta hydroxy acids, then we have trichloroacetic acid in various combinations, we have the alpha keto acids, we have resorcinol, we have the Gessner solution, retinoic acid, etc., etc., the yellow peel. So many kinds of peels that have come in the recent past, and they have really improved the outcome in cosmetic procedures, because they not only improve the skin texture, they improve improve the color, tone, the aging signs in the skin, etc., etc. If you look at the classification of the chemical peels, you can do chemical peels depending upon the depth the peel goes to. You can have superficial peels removing only a partial thickness epidermis. You have medium depth peels which go down to the epidermis and then somewhat to the dermis, and then we have the deep peels which go lower down into the dermis. But as the time has passed and in these days of litigation, we usually restrict ourselves to superficial or maximum medium depth peels because we want the patient not to have a long downtime and not to have side effects, and do more sessions rather than do less sessions and have problems. So chemical peels, as I've already told you, can be used for rejuvenation of the skin on the face, hands, neck. It can be used for improving the color of the skin, the complexion of the skin. We can make the skin tone even. The dull complexion improves with chemical peels. You can take care of fine lines around the eyes, around the mouth, and freckles, melasma, a very difficult condition to treat otherwise. In combination with medical therapy, the chemical peels give us wonderful results, and the rough, sun damaged, aged skin can be made younger with the help of peels. A word of caution about chemical peels: you have to avoid them in situations where you have active bacterial, viral or fungal infections. Patients who have tendency to keloids, particularly deeper peels, have to be avoided in these patients because they can develop keloids. Active facial dermatitis, avoid peeling. Even avoid peeling in a dry, dehydrated skin. The skin should be in a good moisturized condition before you peel the skin. And those who are photosensitive should preferably be used, peels have to be used with caution in these patients. And of course, unrealistic expectations is something that you have to look at in patients, and do not give them not only chemical peels but cosmetic procedures in general, because they have unrealistic expectations and they may sit on your head and tell you why didn't this happen and that happen. So expectations have to be realistic. Now, fillers is another thing that we have been using in the recent past for our cosmetic patients. Basically, they are used to fill up defects in the skin, to restore the fullness of cheeks, the lips, the hollow areas as they develop with aging because of the sagging of the superficial and deep fat pads within the skin. We also use them to improve the appearance of scars by filling up these scars in the dermis. We use them to remove fine lines which are static. Dynamic lines can be taken care of with botulinum toxin, but finer lines, the static lines have to be taken care of with fillers. We can use them to lift the skin now. Now we have volumizing fillers available which, when placed strategically on different areas of the face, can improve and lift the skin like we used to do, we used to do surgical lifts. We can do it with fillers to a large extent now. And fillers have also been used to rejuvenate the hands because with aging the hands can also lose fat and become thin. Microderm abrasion is another new procedure that has come into our practice. We are using it very extensively. A non-invasive, very safe office time, lunchtime procedure which can be used to improve the skin texture, give a polish to the skin, make the skin tone even. In addition to that, it can be used for superficial scarring, for stria, for photoaged skin, for taking care of the contour irregularities. It can also be used to improve transepidermal delivery of various components like vitamin C, like hydroquinone, like mechanol, like arbutin, etc., which are used for reducing the pigment of the skin and for improving the texture of the skin. And we can use it for treatment of aging spots, etc. also. We've even used it for melasma with caution, although post-inflammatory hyperpigmentation is a possibility in this situation. Now, having talked about these procedures, let me take you to the use of lasers in dermatology. The use of lasers in dermatology is rapidly increasing, and over the last say 5 or 6 decades since they have come into use, the understanding of the lasers has increased tremendously. There has been extensive research and better understanding of the laser tissue interaction so that we can give a better outcome to our patients. And there were a number of conditions that were thought to be literally untreatable about maybe 30 years ago, and now we know that these can be treated very easily with the help of lasers. Now, The first laser that was introduced way back in the late 50s was the ruby laser, and this was used for almost every condition at that moment in time. But then as we moved on, newer and newer lasers got into our practice, and the older lasers were improved, and we have now a plethora of lasers meant for different kinds of skin conditions, different lasers for different kinds of skin conditions. Now, while working on our patients, we have found that our kind of skins in our country or in the subcontinent are different from the Western skins. And as we have moved on and used lasers, we have developed our own parameters that suit our kind of skins. We now know that if judiciously used judiciously, the lasers can be a wonderful tool for various kinds of skin conditions. Now, various lasers that are available include laser hair removal lasers, LHR lasers. We have the pigmented lasers, which are usually the Q-switch lasers. We have the resurfacing lasers, which improve the texture of the skin, improve the aging skin, the scars, etc. The LHR, or the laser hair removal, is the major laser that we have in our laser clinics these days, because this is the one that is used most extensively in our practice. And over the years, we have learned that the laser hair is actually reduction rather than removal, and because it does not lead to permanent removal of the hair, it only reduces the growth of the hair and delays the growth of the hair, so that the interval between the growths is reduced. So that is, it's important to explain this to the patient. A large number of lasers can be used for hair removal, ranging from the long pulsed ruby laser at 694 nanometers. We have the alexandrite long pulse, we have the diode long pulse, we have the andiag long pulse, and so on and so forth. But the longer the wavelength, better is it for our kind of darker skins, and we usually do not use the short wavelengths like 694 nanometers in our patients, usually meant for whiter and lighter skins. The darker skins do better with longer wavelengths like 1064 andiag or diode or maximum alexandrite, which are safer. Now, this has come as a welcome boom to the patients of hirsutism. They used to run from pillar to post doing various kinds of procedures for their hair growth, but with the advent of lasers, we can now provide them a very effective way of reduction in their hair. But it's very important to understand the basic problem. You have to know the cause of hair growth, work up the patient properly, assess the situation, treat the patient if required medically in addition to laser, and then give them a satisfactory outcome. Counseling is extremely important, because these patients usually pay through the nose and think that they will have 100% removal of their hair, which is not true. This is to be explained properly, and these patients are to be told that it's only that their hair is going to get reduced by about 70 to 80%. The frequency of the growth is going to go down. The thicker hair are going to get converted into the thinner hair, and also they are to be explained to the possibilities of side effects like blisters, erythema, burns, etc., which we as dermatologists are well equipped to treat and to take care of. They are to be told that as a rule, after the initial completion of the sessions, maintenance sittings will be required every 6 months to a year, depending upon the patient's hormonal profile. Consent form is extremely important, and these are the kind of outcomes that you can get with LHR. The lasers used for pigmented lesions are the Q-switch lasers. Q-switching is a technique where we deliver a laser light in very ultra short pulses, so that high energy is delivered in short period of time, and we kill the melanosomes which are present within the pigmented lesions. And all the lasers that can target melanin as a chromophore can be used for treatment of pigmented lesions, and in the Q-switched form. So we have the Q-switched frequency doubled ND-AG 532 nanometer, we have the Q-switched ruby at 694, we have the Q-switched alexandrite, the ND-AG, and also the intense pulse light. Now, the lessons to be learned about pigmented lesions is that you have to counsel your patient that they are not going to get 100% relief from the lesion. you're only going to reduce the lesion and counsel them properly because of this. Post-inflammatory hyper and hypopigmentation is a possibility, so you should counsel the patient about this and take due care so that this does not develop. For example, you can prime the patient, you can protect the skin from sun, etc. In between the sessions, you can space the sessions well, and stringent sun protection is extremely important. And these are the kind of results you can expect from pigmented lesion treatment with lasers. Now, vascular lesions are treated with wavelengths that can target oxyhemoglobin and hemoglobin as a chromophore, and these are usually around 585 nanometers, and the pulsed dye laser is the best for vascular lesions. But lately we've been using 755 nanometer alexandrite and the frequency doubled Nd:YAG laser also for these lesions. So these are the kind of effects you can have with vascular lesions. And the last is the laser resurfacing. This is a fast developing area, lots of patient satisfaction and very gratifying results we can give with this. Earlier we used to have conventional ablative laser resurfacing, but it has evolved over the period of time to non-ablative and then to fractional. Not only fractional lasers, we also have fractional radio frequency, we have radio frequency per se. So let me take you through these. The ablative lasers would be very helpful, would be used in the older times for removal of superficial scars, wrinkles, dyschromias, rhytids. The two main kinds of ablative lasers that we had were the carbon dioxide and the erbium YAG laser. Both would target water and lead to a diffuse damage of the epidermis and lead to sloughing of the superficial surfaces and improvement in the texture, wrinkles, solar lentigenes, keratoses, etc. And a single sitting of complete dermabrasion with a ablative laser would lead to up to 50 to 60% improvement in the skin. But a very stringent post-op protocol is to be followed in this. They are to be told about strict protection from sun, etc. Lots of side effects would happen with that kind of dermabrasion that we would do in the past. We do fractional now, like hyperpigmentation, which usually would be temporary but would last for a few months. Then more important would be a lot of erythema that would happen, which would lead to curtailment of social activity, contact dermatitis because their skin was thinned out, allergens could enter into the skin easily, acne, melia, scarring, etc. was a problem. So the ablative lasers fell into disrepute because of these side effects that were associated. But these are the kind of effects we use to produce with ablative lasers: complete removal of scars. But this is what a patient would go through: denuded skin, which would take about 15 to 20 days to become normal, and then a lot of side effects, as I have already talked. Then came the non-ablative lasers. They would basically not ablate the skin, heat the dermis and lead to remodeling of the collagen, leading to filling of the scars, tightening of the skin and decreasing the pore size. But they would not do as good a job as the ablative ones. So in came the fractional resurfacing. This is a new technology which can be used both on ablative and non-ablative lasers, where you treat only a fraction of the skin, and with each pass about 10 to 25% maximum area is exposed to the laser, rest is left untreated. And this is done with the help of high precision micro beams which produce narrow columns of tissue coagulation deep into the dermis, and the surrounding skin is spared. Then this coagulated tissue initiates a healing process leading to collagenosis, and we would use this both as a non-ablative. For example, this polymer Lux 1540, we can use it as an ablative like in carbon dioxide, and these are some of the results I can show you. I think with this we can end this talk on cosmetic procedures and lasers for the treatment of aging skin, for the treatment of scarred skin, for the treatment of skin that has dyschromias, that has disturbed tone, etc., that has textural problems. There are a lot of things that we have available these days, ranging from botulinum toxin to fillers to microdermabrasion to chemical peels and then the lasers. Thank you very much, friends.